I'm in Bynum. Some of you know me, some of you maybe don't. I'm a board certified practicing pediatric dentist. I've been practicing dentistry almost 30 years. This is my office. I live in South Carolina. We don't get snow very often, so when we do, we take pictures of it. My husband is a general dentist, so he's Bynum Aesthetic Dentistry. I'm Holly Tree, and then I also run the Tot Spot Tongue Tie and Airway Center. I do laser phoenectomies and work with a lot of different therapists around the area. So this is me. This is my real job, my full-time job. And these are the bad bosses of Holly Tree right here. This is myself. This is Dr. Maria and Dr. Bassam, dressed like we were all referees for Halloween. We did a trunk or treat. And then Dr. Megan is dressed like Princess Leia because she is on maternity leave, but she came to trunk or treat and her whole family was dressed like Star Wars characters. So I put this in here, one, so that you know that this isn't, what I'm talking to you about tonight isn't like me doing things. This is all four of us. This is all four doctors on the daily using these devices. Two of us work every single day and we do 10 to 12 ops each every single day. And we only use electric anesthesia. And when Dr. Nash started with us this summer, he was more concerned about having to use this device than he was about how he was getting paid, how he's going to meet families, learn the schedule, learn the software, meet the team. This was the thing that had him like so wigged out. And now he says he just can't even imagine not using it every day. And then this is our team. Again, this was all of us at Trunk or Treat just a few weeks ago. And it takes a team to get behind this. Like, you're not going to be the one, cleaning these. You're not going to be the one pulling them apart, setting them up. It takes a lot of education and a lot of training for your team as well to get this right. And also a lot of verbiage from your team with patients and families. So I put this in here because I just want you to see the ride that New Smile has taken us on. And they have been diligent and kind to the pediatric dental field since the early 90s, coming up with techniques and early adopters of materials and products. And as you go along this bottom timeline here in 2023, just a little over a year ago now, is when they stepped up and were able to bring the Soan and SleeperOne to the United States. It's been in other countries for many, many years. And, it was New Smile who had the forward thinking and they took the financial risk to really jump out there and be proprietary and get this, under their umbrella. And so now New Smile has a division of New Smile called New Smile Tech. And this is where the Soan and the SleeperOne fall under, is under this New Smile Tech umbrella. And all this comes from a company called Dental High Tech. Dental High Tech is the company that actually owns and develops these products for us. And they're out of France. And a lot of these KOLs, key opinion leaders, teachers, and trainers on this slide right here are in other countries. And Laurie and myself up in that top row were the first two to be exposed and learn how to teach and train others. And I'm so proud to say that as you drop down to that second line and that third line, we've got amazing, amazing instructors and doctors and in the trenches, kind, transparent humans helping to teach this to all of us. Because I speak to a certain population. I'm old AF. Like, people don't want to listen to me, but my business partner is down in that bottom row and she knows lots of people and they relate better to her. So I want them to call her and ask questions. So I'm just super proud, really happy to see where New Smile is taking this. They're speaking to all of us, across the board. So these are all the people on here who can help you and if you already have one of these devices or if Santa brings them to you. So this is what the two devices look like. We're going to kind of unpack them here in just a minute. We are going to just do a very brief summary of the devices because it does look like there are many people on this call tonight, Chris, that don't have them in their hands yet. So just getting a look at them, they do look different. One has a cord, one doesn't. The SleeperOne has a cord. The disadvantage of that is you have a cord, you have to unplug it. It's messy. People see it. A kid can pull on it. The Soan is much more portable. I think I have got some, yeah, here's some of the main differences between the two. The Soan is wireless and portable. There are 2 speed settings on it. Not that this even matters, but I guess if you had both devices in your office, it would matter because the container is the piece that actually holds the carpule of anesthetic. It's called the container. They are longer for the Soan and they're a little bit shorter for the SleeperOne. So if you were using both devices in your practice and you were sterilizing them, that would be something you'd have to make sure that you knew which one you were screwing onto the device, or your team knew which one they were using. The SleeperOne⑤ it is less expensive, but not by much. A few $100s, I believe. Correct me if I'm wrong. There's 3 settings for delivery, and the Soan only has 2 settings. And I won't unpack all that. You can jump on a call with Aaron if you want to go down that rabbit hole and have that explained to you in more detail. Just as a reminder, when we are using these devices, it is a 3-stage approach. The first one is the injection that we're giving into the mucosal, or also known as the periosseal region. This is to numb that tissue right there before we actually do the intraosseous injection. The second part is the manual bone penetration. And our foot is not on the pedal. We are not delivering anesthesia at this point, where our goal in stage 2 is to actually get bone penetration. And then stage 3 is to deliver the intraosseous anesthesia. So it is a 3-stage approach. The one thing that I've seen and been asked about is, and I don't have like a slide or a question in here on it, but my recommendation is give your mucosal anesthetic and come all the way out. Let your patient have a rinse, get that yucky taste out of there, and then go back in and give your second injection, because your second injection is a different angle anyways. You're going to be repositioning yourself a little bit differently behind the chair to give it anyway. So I really recommend that you give the mucosal injection, let the patient have a rinse, then go back in and reposition for stage 2 and 3. So again, here is stage 1 and what it looks like. Stage 1, we're just numbing up the periosteum. We're just looking for a slight blanching of the tissue. And this is a really great idea to, keep that bitter taste away from your patients, is using the isolite, or if you don't use some device like an isolite, to have a piece of gauze or a 2x2 piece of cotton to absorb any of the local anesthetic that leaks, because it is going to leak. It is being delivered at a pace to your pedal, but sometimes it's going to drip a little bit. One thing I do want to say as I get going in this presentation tonight is that I was thrown into the arena tonight a little early. I was going to start giving these webinars in January, and here we are in November with everybody still having beards and mustaches on their faces. And so I did get kind of thrown in here, and very kindly, Paul Bond, many of you know him as well. He's a baddie in his own right on many, many topics. He's at Temple, was very kind enough to provide videos for me tonight, photos for me tonight, knowledge and information for me tonight. As I'm going through these slides, I'm not going to say, this is Paul's information, this is my information, but this is a collaboration between Paul and I tonight, delivering this information to you, and I'm very grateful to him. Stage 2, we're going to get anesthetic down to the bone. I'm not sure if we need to remind the patient of the pressure sensation. I'm more of if they start to feel pressure or start to react to something, say, oh, that's just a little bit of pressure, you're doing great. And then again, you want to watch for any fluid that could be leaking out, or if it starts to bubble up in the vestibule, that tells you you're not giving an intraosseous injection. You're giving some sort of a flim-flam infiltration at that point. As a reminder, when we are giving injections in the maxilla, we can anticipate having diffusion of the anesthetic 2 teeth forward and 2 teeth back confidently. Anything over that is a stretch, and you have to be very mindful of how much anesthetic you're giving, what's the age of the patient, things like that. And in the mandible, you can confidently know that you're going to get 2 teeth mesially and 1 teeth distally with your anesthetic delivery. And how this works is we're avoiding all this soft tissue penetration and it having to sit in the tissue and make its way through the bone. We're literally going through the bone. There's two types of canals, the Haversian canals and the Volkmann canals, that make up this bone, and it carries and travels through there and gets straight to the target, which is the apex of the tooth. This is what a standard needle looks like. Again, we're just making sure people understand, like, why is this important? Why is this different? Under an SEM, this is what a standard needle looks like. It actually rips through the tissue. That's why it is uncomfortable. But when we use these proprietary needles, which are known as the Effitech needles, it is a double bevel and it almost has like a scalpel effect. And it literally like just lays into the tissue and just smoothly goes in there. You don't have to feel like you're poking or jabbing it in. It is pain-free. Now, your first 20 injections, it may not be pain-free because you're learning. Giving local anesthetic, just in our practices. Why is it unpredictable? Because if we've got infection around, we know that we, cross our fingers that we've got some good, healthy, we found a healthy space to get that tooth numb. So a lowered pH with an infection causes us problems. Everyone's anatomy is different, right? Different canals innervate different ways. This is a crazy statistic that the mylohyoid nerve has been reported to be as great as 60% of individuals having a different innervation. And I think about when Malamed speaks, he says, good luck with those inferior alveolars, because that anatomy back there, you're giving a blind injection. You don't really know where you're injecting, what you're injecting, where all that fluid is actually going to. We have a moving target. And this is a great place to bring this up. I saw it, I either saw it on IPEDO or I saw it in the Soan group. Or maybe it was a question on one of our webinars, guys, but the question was, if you have a patient that has poor behavior, wouldn't you want to hurry up and get in there and give your traditional anesthetic and not have to sit in there with the Soan or the SleeperOne as long? And my answer was absolutely, it was on a webinar. And my answer was absolutely not. I would much rather sit there and suffer along with the patient, being upset for the intraosseous injection, knowing then that I don't have to let that child sit there and be scared and cry for another 5 to 10 minutes while the anesthetic works. And then I have to come back in the room and we have, the numbing was the appetizer and now I'm back for the main course. Like, we can get it all done at once and move that patient out of that scared situation a lot faster. And we know, without a shadow of a doubt, that patient is numb. And also that patient's not going to leave there. A lot of these kids that are scared, they're a special needs patient or they're a really, really young child. And those are the ones that can't understand what the feeling of being numb feels like. And we know with these devices, we don't have collateral numbness. So like, it's much better to suffer on the front end, holding that kid still and safe and intimately giving these injections with these devices than to rodeo that injection, leave the room 5 to 10 minutes, and then the kids chewing their face off in the parking lot. So again, a moving target. I feel like these devices are a much better option for that. Needle deflection, a 30 gauge needle is a lot thinner, a 25 gauge is a lot thicker. We're dealing with all of that. And then we also, not only is the anesthetic we're providing unpredictable, but it can also be very uncomfortable. And the reason for that all has to do with pH. So the pH of Septicane with epinephrine is 2.5, with lidocaine it's 3.5, and our standard base pH is 7.5. So either of these canes that we're using, Septicane, lidocaine, even mepivacaine, have a very low pH. And then, you've got the epinephrine in there, which definitely lowers the pH, and that doesn't feel good. So right out of the gate, these anesthetics, our bodies don't like them. They don't like that acidic pH. We're also, when we're giving a traditional injection, we've got the single beveled needle. We don't have the Effitech needle, which is like a scalpel blade. And again, we've got the patient cooperation, dealing with that. The rate of an injection, an ideal injection should be 1 ml per minute. is what a full carpal should take. And in studies, we're pushing 1.7 or 1.8 cc's of anesthetic at a rate of 42 seconds when we're doing traditional anesthesia. So that hurts. That probably hurts. And we're also doing manual delivery. If you've seen any of the beginning webinars, you know, we're relying on our thumb to keep the cadence for us. And we're not as steady as we think we are. So giving that manual delivery, every time we bump or push harder, we're expressing more into the tissue, more acidic and material, you know, fluid, and that hurts. So let's kind of talk about the anatomy here. We've got the cortical plate, and the density increases as you go down towards the vestibule. So we want to be up high in the crest of that tissue. That's why when we look at these videos here in a little bit, you're going to see we're way up high. We're not like down where you would give an infiltration. The insertion for the IO should occur close to the alveolar crest because the cortical plate is less dense in younger patients. It is a great starting place when you are working and learning with these devices. You're going to be way more successful. The Evitechs have that double bevel design to help get through those calcified plates as well. One thing to know is that bone is innervated with C fibers, and the C fibers are the very last things to get numb. That's why when you're doing an extraction, your patient will feel that pressure sometimes, whether you're numbing traditionally or using these devices. And the alpha fibers are very, that's what's in the tissue, right? And that's why we feel pain when we give infiltrations or inferior alveolars, because those alpha fibers that monitor pain are in those tissues. So let's talk about what's happening from the time the needle goes in to the time it gets to where we want it to get to, and what this measurement is. So attached gingiva is about 1.5 millimeters thick. Then you've got the periosteum, which is the next layer in, which is over the bone. Then we've got the cortical plate, which is the bone that's made up of the Volkmann's canals and the Haversian canals. Wake up, everybody. We're talking about science here. Stay with me because I'm going to make a point. And the thickness of that is 2 to 3 millimeters. And then we've got the cancellous bone. So if you add that all up, if you add up the gingival tissue, 1.5 millimeters, the cortical plate, and the bone penetration, you are 6 to 7 millimeters is where we've got to get to. And I say this, and I love this slide because we're so worried. We keep hearing, oh, I could go too deep. I could damage something. I could hit a sinus. I could hit a developing tooth bud. This is just not realistic. These things are just not going to happen. This Evitech needle is 9 millimeters. And if all these things were true and we were at the deepest penetration depth that we could get to, 7 millimeters is going to be it. So you should see 2 to 3 millimeters of your needle hanging out, you know, or exposed from the end of the hub of the needle for you. And that gives you that safety to know that you're at the target, and you can also see your needle, you know, it's not bending, you know, it's not breaking. So this slide gives me some comfort. And this is what cancellous bone looks like. It looks like a sponge, basically, in the mandible, and it's got these small little holes in it and bigger holes in it. And this is how the anesthetic is going to flow, and it's going to flow at a very slow rate, and it's going to absorb, and it's going to completely saturate until saturation is achieved. So if you over anesthetize, if you're giving too much anesthetic in an area, and you've got to think this through when you're treatment planning your cases, right? Like you're not giving, just like you would with traditional anesthesia, you're not like dumping in 2 carpules of anesthetic on a 4-year-old for a DO on S, right? So same thing here. This bone will get saturated with too much anesthetic, and those can sometimes be your patients that are sore the next day because they do have this increased pressure going on. So let's talk about the different anesthetics. You know, this is what we all grew up on here. And, you know, Malamed, he's a big lover of articaine and septicaine, same thing, interchangeable word here, but he's a big lover of those. And the reason that a lot of us on here are lovers of lidocaine is because they were just first to market. This is what came to us in the United States. And then, you know, just like anything, like when I was in dental school, whatever products we used, I loved them. They worked. They didn't fall out. I still use them today. And lidocaine is one of those things on the list. So it's not that lidocaine was any different or better. It's just, it was sort of first to market and what we all got used to using. This is the dose. We all know this. We all took boards and know that how this works. You have to be careful, for allergies, and your working time with a carpal of this is about 60 minutes, and it's about 60 minutes intraosseously as well. Septicane, on the other hand, your dose is a little bit higher. It has a much different molecular structure. We're going to look at that in just a minute. One of the best things about septo is its half-life. It has a 27-minute half-life, and which means it eliminates the body quickly. It also doesn't go and get metastasized in the liver. It gets metastasized in the blood. So a much safer alternative for breastfeeding or pregnant mothers. Again, we have to look for these precautions with allergies. And if we're infiltrating with septo, we get about 60 minutes, and intraosseously, we get about 45 to 60 minutes with the 1 to 100. 1 to 200 is where we're going to live most of the time using the Soan and the SleeperOne⑤. And this is the same thing, the same dose. This is the same makeup, same allergies we're worried about. And this is going to give us less working time, but truthfully, how often are we working more than 35 minutes on a kid doing operative, right? So this is our sweet spot. This should work really well for us. One of the reasons we don't want to use 1 to 200 on the daily is because when it does increase the amount of time our patient is numb, but there are more studies for ischemic reactions and discomfort because of the concentration using the 1 to 100. So this is what this makes me want to throw up in my mouth looking at this organic chemistry right here. But this is what the organic structure of these, they do look very different. Lidocaine looks very different than articaine or septicane does because it has this thiophene ring on it instead of a benzene ring. And what that really just means for you is that the half times are completely different. You're going to get rid of the, it's going to be out of your body, out of your system, out of your mouth, everything much quicker. And, it's binding at the site a lot better. It's lipid soluble. That's why we want you to use it with these devices because it is lipid soluble, it's going to pass through that bone a lot better than lidocaine will. It's almost like lidocaine gets blocked. And even if you're not using these devices, here's a reason to think about switching to septicane anyways, is don't you want this being, metastasized in your blood instead of in your liver? We got one liver. I'm destroying mine tonight with tequila. I don't need lidocaine running through it all the time. So there's a reason right there to switch. All right. What excessive local looks like. The pH of most local is very acidic, and that's mainly due to the epinephrine that is put in these into these carpules to hold the anesthetic at the site. Adding more acidic solution, it just increases the volume. It results in lowering of the pH in the tissue. As the pH decreases, the body is unable to neutralize it, so it's just sitting there. Again, this can lead to being more uncomfortable later. Lower efficacy due to decreased nerve penetration, and the increased volume increases the risk of toxicity, which hopefully nobody on this call is getting anywhere near a toxic dose or amount of anesthetic with our pediatric patients. Topical anesthetic, yes or no? Both. Totally up to you, how you feel about it. It's a personal preference. I would say that for somebody first using the devices and you're just like not sure about putting a needle in somebody, it gives you the confidence of like, oh, I've numbed the tissue before I put it in. One thing to think about though is if your assistants are placing the topical first, we're not placing, like in this photo, that would be where you place the topical for an infiltration, right? For these devices, we're placing it in the papilla area. So, you do have to retrain your team as to where they need to put the Q-tip of anesthetic. And then also have your team, be using some sort of a suction device in there or put a cotton roll in there to get the yucky taste out. Advanced users, again, personal choice if you want to use topical or not. When I do the beginner webinars, I recommend everybody to use topical or at least put a Q-tip in the kid's mouth so that you have a litmus test of the behavior of this, kid that is, could show out or act crazy or, yeah. And I love that. I want a parent to see like your kid's acting a fool with a Q-tip. So it's about to go downhill really fast. So again, personal choice if you want to consider the needs and the level of anxiety of yourself and of your patient. And again, none of this stuff tastes great. Local anesthetic doesn't taste great. There's no topical that tastes great. So just, be compassionate with your patients and, and make sure your assistant's in there getting all that out. So the two different needles, the Effitech and the traditional, this is just really the differences between them. The two major differences are one works like a scalpel, the other one is is poking you basically. And the second thing that we probably all care about on here is the cost. And the cost difference just really isn't that big. I mean, a traditional needle runs about 18 cents and an Effitech needle runs about 27 cents. The strategy of using the needles, this is just a great picture. When you have your needles, they have a D on them. The Effitech needles have a D on them. Chris, why don't you tell us what that D stands for?
It stands for this side up.
Yep. We're very
That's what it's.
professional at New Smile and Dental High Tech. It's this side up. So the
This
D has
side
to be
up.
pointing this side up, or the needle goes in wrong, and then this hurts. We're going up under the periosteum. This does not feel good. So by making sure that you have the D on the needle this side up, you are penetrating in the right position and giving a comfortable injection. The needle should be changed after a second injection site. I push the limit on this, especially if I've got a little kid and I'm working in 2 quadrants and I pop right in on the first one. I'm going to push the limit and I'm going to attempt to pop right in on the second side. But again, if you can't get in, just change the needle. Have plenty of needles right there on the counter. Don't make it hard for your assistant. Have to go 4 drawers deep in the counter to get another needle out. Make sure you have these needles readily available on the counter for you. And if you do have difficult penetrating, just replace the needle. I prided myself on, like, I have never bent a needle in a kid's mouth, like, ever. I don't know why, I just never have. And freaking last week, I bent a needle in a kid's mouth and I wasn't doing anything different. I don't know if I don't know, it bent on me and I had to switch the needle out. So soft tissue paresthesia, this gets talked about a lot in the forums and on different questions get asked about this because patients will report that they have some numbness down here. And what that is about, it's not anesthesia, it's paresthesia. Anesthesia would be you could work in this area, you could poke and explore through their lip and they wouldn't feel it. If you poke through their lip, they're going to feel that. So paresthesia is just a little bit of numbness. It's not like profound numbness. And these are the reasons that that it can happen. So obviously using the IO technique, it's going to reduce lip anesthesia dramatically. But you can get some paresthesia, especially in younger patients because the bone is so porous, but it doesn't last very long at all. And it depends on the age and the density of the patient. And really your biggest thing is that you've got the mental nerve and the canal right there, right? We've all said that everyone's anatomy is different. No 2 patients are the same. So while you're in there injecting, some of that anesthetic could get near the mental nerve and it can travel into this area and create that paresthesia. The lingual nerve is never affected when you're giving an IO injection, so you should never expect or anticipate that your patient is going to tell you that their tongue is numb or that they're biting through their tongue. So since most of the people on this webinar tonight have the Soan or probably are requesting a Soan from Santa Claus, let's talk about what these 4 dots mean on here. So as you're giving the stage 2 and stage 3 of the injection, these dots are talking to you. They're flashing. And as the dot is flashing, that's letting you know anesthetic is pacing and being delivered. This is telling you when there's only 1 dot blinking that everything's going great. It's not hitting any resistance. When you start to see 2 dots, there's a little bit of resistance. When we get to 3, 3 gets my attention. When I see 3 dots blinking, I start to wonder, what is going on here? Why is there so much back pressure in this device right now? And 4, it's pretty much stopped and it's going to reset itself at this point. We're going to talk a little bit later about why this happens and how we can prevent this from happening. But this is a really cool part of these devices. They're like little computers in our hands and they know what's up. They know real quick what's up before we do. And they talk to us and they tell us this information down here. So this is just a brief slide explaining that. Let's talk about the canisters. These are the or containers that hold the anesthetic in them. This is what they look like. These are the long ones and the short ones. They cost about $20. Are they about 20 or 25?
$20.
They're $20. Okay. And they come in sets of 5, right? When you replace
5.
them. So you
Right.
can't just like order one, you buy like 5 at a time. And you want to be like real clear with your clinical team about these. These do not get thrown away. Do not let them throw them away if they see one little crack or craze line in them. These will go the distance for you. They are not disposable. They need to be run in your M11 or your Statum or your autoclave or whatever. The company tells you that they have a lifespan of about 50 cycles. I'm going to straight up tell you I've had my devices for a year now, and I don't think we've ever ordered more canisters. They may look a little ratchy, but they're still getting the job done. The new canister is clear. It has a little bluish hue to it. It does change the more that you run it. And it will start to look hazy and it'll get these like crack lines in it. And, obviously once the integrity of the canister is no longer intact, you do need to throw these out. If the threads start to crack and it, won't be held onto the device well, get rid of these canisters. So I'm going to go through this slide like super fast, but a mandibular block, yes, you can give a block with these devices. If I don't know, what you just get a wild hair one day and you want to give a block, this is how you would do it. You got to have it in high mode, not low mode. And obviously you're going to want to aspirate if you're giving a block. So the little arrow there to the left would be what you would step on to, produce the aspiration. You can, watch these slides in your bubble bath later if you want, refresh yourself on these if you want to learn how to give these blocks. But these are the steps for how to do it, or Erin can help you while you're in your bubble bath, how to give a block. All right, so let's talk about cases and case selection. You definitely need to know your medical history and kind of figure out where you want to give these injections. You have to rely on your x-rays. We're giving injections into bone, people. If there's no bone, you're not giving an intraosseous injection. So you have to really step back and rely on your x-rays a lot more. You're not just looking at your x-rays for decay anymore. You're actually studying the bone. You never want to inject into an active infection site. You need to have really good dense bone. And you have to have the right angle. Look for, weird things, obviously, supernumerary teeth or any pathology. Again, we've got to be really paying attention to what we see on our radiographs before we come at our patients with these devices. The 4 ways to be great at this: use the appropriate amount of anesthetic, or the appropriate anesthetic solution, which in this case is septicane, inject the right quantity, be gentle and take your time, be very patient. Don't just like, oh, I didn't get it. Oh, I didn't get it. And like, poke, 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 poke. Just be patient and work your way, whittle your way into the bone. And then you want to be as close to the target as possible. So how much anesthetic should you give? Same things you're thinking about when you're giving a traditional injection, right? What's the size and the age of my patient that I'm working on? How many teeth am I going to have to work on? What am I doing on the teeth? Am I doing an occlusal on T, or am I extracting S and T and they're really broken down and infected? And then how much time do you need to get it done, right? Because we all work at a different pace. So planning out your cases, I would be pulling out a bite wing and a pano sometimes when I'm trying to plan where to give anesthetic. That's super important. So let's look at this pano right here. If we, blew it up into a bite wing or into a PA like this, we could say, okay, well, we know that we've got to get out those 2 primary molars and we've got to do some work on that permanent molar. Bang, there's a good spot right there. I can get everything done that I need to get done if I inject right into that spot. Here's another great time where you would want to get out a PA and your pano. You're looking at the PA, you need to get in between those molars and do some work. Maybe you think you can't, but when you look at the pano, you've got a different angulation there. And we're looking at all 2D images here, right? So this image is put together, knitted together much differently than a PA is knitted together in our radiograph, machines. And you have plenty of bone right there between those 2 molars to give an intraosseous injection. So don't just rely on one x-ray, and also don't just use your x-ray either. Like look in the mouth, see what you're dealing with here, right? Again, the mouth is a 3D thing and an x-ray is not. So if you looked at the x-ray, you think, I just really don't have anywhere to go, but you've got a great spot to go right there for the work that you need to get done. You can numb right there and you can get those 2 molars out, no problem. All right, here's a great case. We're going to work down here on the bottom, and that little X right there is showing you where the anesthetic is going to be delivered. This side up right there. This is given the first injection. And we're not going to sit here and watch all of this. But you can see this is Dr. Bond or one of his residents, and they just like laid the needle into the tissue. I think we've got here we go. Yep, now we're taking it out. We're not giving a rinse because we're a resident and we don't care. And now we're giving the second injection. So you see the angulation changes. We're no longer worried about where the D is located, and they're confident they are into the space. We've got 2 to 3 millimeters of needle sticking out at the hub of the needle right there. And we're out. And see, it drips like that sometimes. So that is, that's a thing. You want to have your assistants there, getting all of that out, because also remember, this is being delivered under pressure and force. So as you're, even though your foot's off the pedal and you're taking that needle out, there's still some back pressure, and there can still be some anesthetic that wants to be released as you're coming out. This is an anterior case. You're like, oh, I got to get out tooth F. What the heck? So we're going very far away from that, from where that infection is. We're actually going almost, at the top of E with the first injection, and then the second injection, we're just trying to stay away from that infection right there. But that's a great strategy, a great way to get F numb. It's going right there. Here we go. We're going to show, this case is really great because it's going to show, this is showing the stage 2 and stage 3, giving the intraosseous injection portion. And then they're going to extract this tooth, this second molar. No back pressure. We're good. We're getting the tooth out with a cow horn. Tooth is out. And this is one of the other great benefits of using intraosseous anesthesia is, I don't know, it just doesn't bleed. Like you're not just sitting there and you don't have a soup of blood when you're done with these extractions. This is what the site looks like literally 30 to 60 seconds later. Here's an anterior case, same thing. Again, 1 injection and we can get all 4 of these teeth handled compassionately for this patient. So giving stage 1 up there in the top right corner, lower corner, giving stage 2, and we're going to take these teeth out. And again, this is what it looks like literally 60 seconds later. They're just not oozing. The tissues, it looks good. Mom's not leaving, with it looking like a war zone with our kid. Here's some anterior cases. Again, these are Paul's cases and his students, but because I think I wouldn't want to do this in my practice. But this is like adult dentistry. I would kick this over to my husband. He would do all this. But here again, here's a good sweet spot of bone right here. We can numb in between the lateral and the central. And we're going to do that. And then give the first injection, give the second injection, prep the teeth, restore the teeth, take an x-ray of the teeth. My favorite picture of this case, if you are going to do anterior work, you ask the patient to smile and their lip is not hanging and drooping down. They can show their parent or whoever, or they can look in the mirror and like see their smile again. Think about the kid that has trauma, right? I just did a trauma case this morning, actually. And they can smile and they can see because they don't have the collateral numbness, which is really nice for cosmetic cases. This is my husband's dental assistant's little boy that I worked on last week, and we're going to do some work between I and J up there. So just showing the x-ray, I've got a nice little piece of bone right there that I'm going to parse and find. I've already given the mucosal injection, so here I'm going with my second one. And I like this video because when I did it, I knew I was going to want to show it in here, and I pull back. You see me tugging on it. I like to do that. It gives me the confidence that if I can't pull the needle straight out, I'm probably in some bone. So I like to do that every once in a while, just for my confidence meter to be like, oh, I'm in there, I'm good. Again, given the anesthetic, I tell everybody, like, really choke up on that. You'll have a lot more tactile sense the closer you are to the end of your syringe or your needle there. This is a case that I did on Monday. I'm going to extract this canine. And if you look to the mesial of the canine, I've got a follicle of a permanent canine right there. So I'm like, oh, I don't think I have any good bone there. I'm not trusting that I would, that x-ray is really good. So I'm going to go in between the the first primary molar and the canine to find some good bone right here. Again, I've already given the stage 1 injection. So going in, I popped right in. Such a good, confident feeling. It doesn't happen all the time, but when it does, you're like, I'm there. That's good. And one thing you can tell your patients is, oh, we're going to listen to one song while I take your temperature on this tooth. So they're zoned out listening to whatever nonsense they've picked on Alexa. This is a case that Dr. Nash did yesterday, one of my associates, and he's going to extract I and J. Obviously, there's something going on back there, nasty. So he's going to go in between I and J. He's staying away from the impetigo on the lower lip. But I love this. He's very choked up on the device. He's twisting and turning. He's being very patient. And he feels very confident once he's in. And he's not stepping on that pedal. He's not starting delivery until he knows he's in. And then he'll start. We're not going to watch that whole thing. Hypoplastic 6s. This is the mic drop right here. Everybody needs these devices just for hypoplastic 6s alone. Paul Bond is like the king of hypoplastic 6s. And he's done so many amazing things with restoring them, saving them when they don't look savable. And he says he doesn't even know how he did them or practiced as long as he did without having a Soan in his hand to do them. Basically, what you need to know is like 90% of the time you're gonna nail it. You're gonna get these teeth numb. Whereas like it's usually 30 or 40%, at least in my hands, doing it traditionally. I'm coming from every angle. I'm giving 2 to 3 cartridges. I've pulled out every anesthetic type I have in the drawer. And then I'm probably still sending the patient home because I didn't get them numb. All right, let's talk about some things that have hit the Facebook group because I think these are great learning moments. These are true things that came onto the Facebook page. Why is the local still coming out of the syringe when I am not pressing on the pedal? And we talked about it. There is some back pressure left in there. If you're removing the device from the patient, you will have some of that. But if it's out of the mouth and it's still running, you need to check and make sure, like, are you in the right mode that it is still like pushing anesthetic out? So that is usually the number one reason. And then another question that gets asked is, how does the pedal communicate with these devices? And it is radio frequency. There are no batteries. Nothing is going to be dying on you or need to be charged or need to be replaced. So that is how it works. It's like some little magic fairy down there using radio frequency, keeping your device alive. I did not feel the pop into the bone. Did I do something wrong? No, you're not always going to feel that. When you do feel that, that's like your litmus test, your confidence boost that you're in. But sometimes it'll just slowly mash in there. Sometimes you'll have to work it in there. And sometimes it doesn't go in and you have to reset and start over again. So likely not. Again, if it's softer bone, it's just going to slide right through. It may just go pop right into one of those open little vacuoles in the bone. And like I showed earlier, you can get some, tug back on it to make sure you've got some resistance. I don't have buccal bone available because there's an abscess and the buccal plate is messed up. What can I do? And this is when you have the option to go lingually or palatally. And if you are going to do that, the bone on the lingual is a lot kinder. You can actually get into it a lot easier. It sounds so counterintuitive from what we do on the daily, but it is a good option for you if, when you're trying to think outside of the box on some of these cases and you have to be strategic. I was pressing the pedal, but the light was not blinking on the unit. It could just be that it didn't catch. So just take your foot off, try it again. Maybe the unit was too far away. You need to bring it a little bit closer to you. And then also, if you're running more than one of these devices from room to room, the pedal only has one master. So the device and the unit go together. You can't run them off of a different pedal. So make sure that you haven't swapped out the wrong pedal with the wrong device. I finished a carpal and the unit reset. And if you've done this, sometimes I'm looking away and not really paying attention. I'm probably talking. And when it resets itself, when that plunger wants to reset itself, that you feel it in your hand. It's like a vibration sensation that plunger is retracting. And when it does that, sometimes you will see blood in there. So they're asking, like, when this happens, is that okay? And yes, it's completely normal to see a little bit of blood in there. That's nothing terrible. What post-op issues have occurred using these devices? Obviously, tissue irritation, the tissue can necrose. A lot of these things are the same things that you can get from giving traditional anesthesia. If the patient picked at it, you could have some, if you used a rubber dam clamp, you could have some trauma to the tissue from that, and that can be sore. We talked earlier about making sure you use the right amount of anesthetic, because if you push the limit and you push too much in there, yes, then that creates some pressure and that can be sore later. And just, we call all of our patients in the afternoon. We only do treatments in the morning and we call them in the afternoon to check on them. And, now we're not having to hear she chewed her lip or she's still numb or she's pissy because she couldn't eat or all this. We're not listening to that. But every once in a while, the parent will say that their kid is sore, and you just want to make sure that your team is reassuring the family that this is normal and it's, it's going to be okay. So again, too much delivered. My two that I added on here were, if you're on a learning curve, yeah, your patient may be a little sore. You don't know what the hell you're doing yet. I'm pretty sure your first couple patients, or when you were in stab lab working on your dental students, we were all sore those first couple of days because none of us knew what we were doing. So, the trauma of just learning the devices and using the devices can make your patient sore. But also, if you call on your patient sore, think about what you did to the patient. Maybe you were like doing 2 pulps and crowns and you were like way underneath the gum tissue, or you did a nasty extraction. So when they first tell you on the phone that the patient's sore, don't jump straight to, oh my God, I bet they're sore because I use this new device. That's probably not it. It's really probably not it. Some common questions that New Smile gets hit with and we get hit with as KOLs is, what are the reasons that the local won't flow and the light goes all the way up? And I said I was going to touch on this. One of the reasons can be that you've got that needle pressed right up against bone and nothing can get out of it. It's just truly a physical problem that you're up against. Another thing is the needle can be bent. It's in there somewhere and it's bent and you don't realize it's bent, and now you've created a backflow and it won't go. Or another thing that can happen is as you go in, spicules of bone get in there, especially if you're going to push the limit and try to inject at a second or a third site. You're probably going to be picking up some spicules along the way, and it can obstruct the needle. So what are you going to do about this? First thing is be patient. These machines are very, very smart, and a lot of times they'll fix it themselves. If I start to see 3 lights, I'll watch it for a minute, and a lot of times it'll just go down by itself. The second thing I'm going to do if it doesn't do that is I'm going to reposition a little bit. I may pull back a little bit. I may just turn and twist a little bit differently and see if those lights will give me a little bit better information. And then if none of that is working, you got to come out and you got to just replace the needle and go back in. And that's not a big deal either. Another question that gets asked is, can you go from the buccal or the lingual for delivery? We kind of already talked about this. Yes, especially when you're having to be strategic and looking for good bone. There is no contraindication for doing this from the company for either of these devices. And like I said earlier, sometimes the lingual bone is easier to punch through. And it is funky in certain quadrants, depending if you're right-handed or left-handed or how your rooms are set up. it is funky and hard to get in the right position. We talk about this in the beginner webinars, getting your body and your patient and the device, strategically positioned to get the most successful injection. So sometimes going from the lingual is just easier and better on everybody. How do I aspirate with these devices? I don't really see a need to aspirate. I guess it would be if you're giving an inferior alveolar injection and you want to aspirate and make sure you're not picking up any blood. There is a way to do this. That's what the little triangle arrow is for right there. It will aspirate for you, but it's a computer again. It's not going to start the aspiration process until at least 1/8 of the carpule has been delivered, because it knows there's no safety risk of, if you just injected 1/8 of a carpule, you're not putting someone into an arrhythmia or a tachycardia from anesthetic at this point. And the really cool thing is, yes, you can use these for traditional injections. If you've got a kid with an over-retained tooth and you don't have any bone anywhere, just use it to give an infiltration. Just use it, use it that way. And I have a friend, she fell, she had trauma, she's an adult, she's a hygienist, fell, blew her face out. She had to have endo and crowns and all this stuff, and her frenum looks like terrible. I call it a dingleberry. She's got like this dingleberry hanging off her frenum now. So she came in yesterday after work and I used the Soan on her. She'd never seen it. Her office doesn't have it. I explained it to her. So, and her 8-year-old daughter was there too. So I removed her dingleberry by using the Soan. Her 8-year-old daughter watched. And then on her 8-year-old daughter, she's in ortho and she's got some pull down here between 24 and 25. And her mom was like, "Can you use it on her too?" So her daughter, who just watched her mom get a needle shoved in her face from this device, climbed in the chair. I numbed her up with it. She felt nothing, and there was no bleeding either. Like it was totally awesome. So yes, please use these. Please don't pull out your traditional syringes. These are this is a very compassionate way to help your patients. There is a learning curve. I'm going to go back to that right there. So to set yourself up for success, primary dentition, you are going to bend needles. You are not going to break needles. Needles just don't break. Get over yourself. It's not going to happen. Choose the right injection site for success. The more anterior you can go, the better. I feel like, because you have more control of the device. Get a good grip on the device. That's super helpful as well. And in summary, these techniques can address a wide array of local anesthetic needs that we all have in our practices. These needles are where it's at. They do deliver a painless injection. For any of you who are certified for Botox or fillers, there's a needle called the Comfort Tox needle, and it's a very similar strategy that you are making it less uncomfortable as the needle penetrates through the skin. So I equate it to that. Dramatic reduction in local administration doses. You don't have to give as much. It's much more predictable. And like I said, those hypoplastic 6s, this is a big confidence booster when those end up in your chair. Immediate delivery of anesthesia. There's no downtime. You can go check hygiene if you want, but you can stay right there and help your patient out and get done and get that room turned over quickly. No one's chewing their faces off. And you've got to be patient. You've got to, there is a learning curve with this, and everybody's learning curve is a little bit different, but I put this up here at the end of this slide because this is our son, and he's a D2 dental student at MUSC, and him and his buddy came to the office a couple weeks ago, and they were scanning themselves to make some retainers and some other bull crap stuff, but they use the devices on each other. I let them use them on each other, and they haven't even given traditional injections to each other yet in dental school. And they would, just with my guidance, just standing over them, telling them about the devices, teaching them how to use it. They injected each other in 2 quadrants each, and they have learned this. So I'm telling you that if a dental student who has never even used anything before can do this, not that my kid's like some great whatever, I'm saying like these kids are dipshits. They don't know anything yet. And if they can come to our office and do this, if you have this device, take it out of the box and let's get going with it and call Aaron and get on it. So how are you going to learn it? Don't stress out about it. You've got a great team here to help you. Chris is, oh my God, this is like flying through here. Sorry, guys. Chris, again, who's on this call, and Jordan, who's on this call. They're here to help you and train you. This is their information. I think they said they're going to drop it in the chat as well. And then I've got Erin over here. She's an excellent trainer. She can troubleshoot anything. And they're all here for you. So when I tell you they are accessible to you and they want you to get this right, and there are no dumb questions. It does not matter if Erin can go in and she can see that you've sat on 5 of these masterclass webinars and you're still calling to ask questions. She doesn't care. She wants to help you. She wants you to use these devices because the goal is to be compassionate and help our patients. And we can't do that if the device is sitting in the box or we feel like we're asking stupid questions. Online support, the New Smile website and the New Smile Tech website, all these webinars that we're putting on. God, I hope this one gets deleted tonight, but for the most part, all these webinars are available to you at any time. Luke, my son, had some of his buddies watch one of the webinars recently. They're all coming home. The ones that live here in Greenville are coming home for Thanksgiving break next week, and we're going to have Stab Lab up at the office together. So they're all going to get to use the devices. But I said, I want them to watch some of these webinars. Greatest thing they ever came up with was this, this user group, because there is no judgment passed at all, no shade thrown in this group at all. This is where you can learn. I go in there to learn. I love reading everyone's comments. Dr. Prin is on a different time zone, so he usually beats all of us to it with his brilliant answers. But this is a great group, and you do not have to own one of these devices to get into this group. This is not like some private club. This is get in there and learn from other people. And you're going to learn from the people who have like screwed up or bent a needle. I need to show more of those cases on here, my flubbubs, so you can see that, none of us are perfect out of the gate. Like I said, I bent a needle last week, so, and just move on. And then the last thing I just want to say is, if you want to get more in-depth training or on-hands training with anything that New Smile is doing, they are putting on their next Restore course is in February. Chris, if you want to say anything about that course, I don't, it's kind of like 2 courses or 1 course you can take together. What do you want to say about that?
Yeah, it's so Saturday, Sunday. Saturday is restorative. Sunday half day is tech. So Soan and SleeperOne scanner. It's almost sold out. Not a sales tactic. It's the truth. So if you want to come, definitely let us know. But it's getting close. We're running out of room. So hopefully we'll see you there.
I'll be there. It's Fort
You
Worth.
will?
Fort Worth. Yes. And then down here in the lower part of the slide, New Smile is putting on the Pediatric Dental Pearls. It also is getting very close to being sold out. I know they're limiting that number, and this is just for the ladies. Sorry, guys, just for the ladies. And this will be April 4th through the 6th. And lots of great topics. You can go to the website and you can check out who the speakers are and what the topics are. And I'll be at that as well. I'm looking really forward to just, spending some time with some amazing pediatric dentists at that as well.
I'll be there.
And with Erin, she'll be there. None of the boys will be there. This is my digital contact card. If any of you want to reach out to me, I love it. I have people who have watched webinars 6 months ago and they'll reach out and still ask me questions. I want you to ask me questions. And if I don't have the answer, I'll get the answer. I'll figure it out. I'll help you. I want to see everybody. I want this to be the standard of care. I want everyone's patients. It's kind of like when I went from the diode laser to the CO2 laser. You can't go back. I can't go back. I know how compassionate the CO2 laser is compared to the diode, and I feel the same way about these devices. So that's why I'm so heavily involved, is I want all patients to have this level of care. That's all I got, boys and ladies, guys and girls.
Awesome.
Studs.
Can we give Anne a round of applause? She was so nervous about tonight, and she did great. She did great. So thanks again. That was fantastic.
Yeah.
Couple of questions coming in here. Looks like more and more. So we'll get started again, guys. Just submit those questions in the Q&A. We'll ask them, and Anne will give her response. If we need to respond as well, we'll jump in. But we'll go ahead and get started with the Q&A. First question, kind of 2-part. Once you place the needle into the bone, do you still continue to push slightly or just stop? I am finding that the least slight pressure once in the bone will cause the plunger to retract.
The second part of that statement, I have not had happen, so I really can't comment on that. I haven't had the plunger retract on me by
It's
pushing.
Dr. Howell, so he has a sleeper one, so that might be a reason that it's retracting.
Okay. But the first part of the question is no. Once I hit bone, I don't try to keep going. I feel like especially if I pop in, I'm good.
Yeah, the other part to that too is, I mean, if you're not fully through that cortical plate and you're just, sticking into just the cortical plate and not into cancellous bone, that unit is going to sense that pressure more so than it would in that spongy, soft cancellous bone. So it could be giving some feedback that it's getting that resistance, which is causing it to stop.
Got it.
Next question. We have a comment and a question. I love my Soan, have been using it on most patients 8 to 9 years of age or younger. Has been amazing. Couple of questions. How long do you leave the needle in for the mucosal infiltration? I'm worried I am leaving it in too long. Let's start there.
I want to ask, how long are you leaving it in? But two answers to that question. I'm watching it blanch. So sometimes I'll use the visual test to tell me, oh, that tissue is blanched plenty, so now I'm coming out. But if I were counting, I would probably say anywhere between 5 and 10 seconds. It's not forever.
Yeah. And the IFUs for that too is you're basically looking for about 3 to 4 millimeters of blanching size, of that residual blanching size. So once you get to that point too, you can rest assured that periosteum is anesthetized.
Yeah.
Second question from the same person is, on average, how much local are you giving for the IO part? Example, for a standard MODO on S&T, how much of the carp is used?
That's a great question, and I'll kind of go through the myriad of what I would recommend. And there are no standards on this. There's not like a cheat sheet on this, but if I'm doing MOs and MODOs, I would probably give a quarter carpule, no more than that. Pulp and a crown, anywhere between a half a carpule or a quarter carpule and a half a carpule. Anything that's hot, like if I think I got a hot tooth on my hands, 3/4 of a carpule. And a hypoplastic 6, a full carpule. That's for me. That's for my benefit. And those are like the 4 lanes that I stay in: interproximals, quarter carpule, pulp and crown up to a half a carpule, hot tooth up to a 3/4 carpule, and a hypoplastic 6, a full carpule. That help? I hope. That's a good little cheat sheet, I guess.
Yeah, for sure. They did have another question. Any tips for anesthetizing older kids / permanent teeth? I've bent a fair number of needles on older kids. This would be a good opportunity to show the video of you getting it done on yourself, Anne.
I know. I know. I took that out because that's in my baby videos. But
Yeah.
I think, Brian Richards, I know he's on here, and he responds to this when people ask the bent needle questions, is really just focusing on keeping the unit in the long axis of the needle. As anytime you teeter off at all, the weakest point is going to be the bend of the needle. That's where the integrity is going to be lost. And you do have to give a good bit more pressure on older kids because their bone is more calcified, less cancellous, I guess. And so you are, having to work at it a little bit harder. And so you have to really make sure that your hand positioning, that you're not going, off track, and you're staying in that axis. So I would tell you to stay with it. I would tell you to really pay attention, make sure you've got your fulcrums on there, your hands and your fingers are in the right positions, that you're not just out in space using the unit. And it's just part of the learning curve.
All right. Next question is there any objective way to show parents that the teeth are numb, has profound anesthesia if the child is struggling with treatment after the IO injection?
I mean, the tissue around the tooth is numb, so you could put a explorer into the tissue right there, just like, just kind of like what we do when we give a traditional injection, and you want to show a parent, where you've numbed, and you can put it in there and show them that. The other thing you can do is, this has no correlation to these devices, but something I do if I think a kid's being a fool, we've all done this, is you run the handpiece on a tooth on the completely opposite side of the mouth for 2 seconds, and the kid like falls out on the floor like they're dying, and then you look at the parent and like, your kid's a joker. Like, I don't know what to tell you, right? Like, that's a good litmus test to show a parent that that's like they're reverse engineering it. You're showing them that, look, he's acting just as crazy on a tooth that isn't numb or shouldn't be hurting, or I'm hardly doing anything to. But you can also, I would think sticking like an explorer around that tissue would show them.
Yeah. Yeah, absolutely. We have a comment slash question. I'm finding it taking about 3 minutes to deliver a half a cartridge. Is this standard? I just want to make sure I am doing everything accurately. What is the average time for it to deliver a half and a full cartridge?
I don't know the answer to that.
Jordan, can you jump in, or Aaron?
Yeah, so the average time to deliver about sorry, can y'all see me? My camera did a weird thing there.
Yeah, we got you.
Average time to deliver about a half of a carpule. It typically takes anywhere between about 1:20 to 1:30 seconds. So even though it's a milliliter per minute, it speeds its way up to get to that point, which takes about 25 to 30 seconds to get to that top speed of 1 milliliter per minute. So a full carpule will take you about 1:45 to 1:50 seconds, where a half carpule is about 1:20 seconds-ish.
So 3 minutes seems excessive.
It does. So what's going on there is, most likely, if I had to guess, would be that there is a buildup of pressure. So when there starts to be pressure, the device slows its rate down to try to equal itself out. So it's not injecting too quickly.
The other thing that I would ask you, Doc, is, when you're delivering the solution, every time you step on that pedal to start the delivery of the solution, and every time you take your foot off to stop it, if you go back on, it starts that ramp up process from the beginning. So it starts again with that slow drop by drop by drop, and then ramps up again to that kind of cruise speed, if you will. So that could also be making it a little bit longer if you're having to come on and off the pedal for whatever reason, but just be conscious of that.
And maybe a suggestion is to do it outside of the mouth. Put your foot on the pedal and time it. And if it's taking 3 minutes in space to do that, then something's maybe not right.
Yeah, that would be maybe a setting change or something that we could look at, for a repair or something under warranty. But that's a good idea as well.
Mm-hmm.
All right, next question. How do you know how much anesthetic has been given?
Well, it's same as a traditional.
So you can visualize it in the container. The containers are completely clear, so you can see where the plunger is inside the clear container in the carpule. The units also notify you every quarter of a carpule. So at quarter of a carpule, it'll beep and flash a light. Half carpule, 3/4, full carpule, it'll let you know.
And I would tell you not to don't fall in love with the beeping, because you're not going to hear the beeping. Your HVE is going, Moana's playing on the Alexa. You're not going to hear whatever the beep thing is. So I would just say like, it does beep at you, but don't use that as like your test on that. You can see, like Chris said, you can see that carpule move.
Somebody said also, I'm also finding a few patients, they are sensitive to rubber dam clamps after IO, but seem fine when I use Isolite. Do you think this is due to pressure or not reaching the lingual or mandibular teeth?
I think it's due to pressure. I think it's like we talked about those C fibers because, and I wish you could bring Brian on because Brian is I don't know if you can let him in, but he's like a rubber dam aholic and he doesn't have any problems with it.
Yeah, I can let him in. Let's see if he's there, if he's paying attention. Let's see if he's paying attention. Hold on, let me find him.
Make sure you turn his video on too while you do it.
Yeah, he's got to have his video on. Let's see. There he is. All right. Dr. Richards, you are on, but you are muted. There he is.
Hey guys. Yeah, no, I would say that if you're having troubles with the rubber dam, it's one of two things. It's either pressure, like Ann said, that's a photo, or that's a pseudo pain, or possibly not in the right spot with the intraosseous. I only give one injection and I use a rubber dam for everything. So
Do you
it's
use
not
it for prophies?
I don't use it for prophies, but I do use
Okay.
it for sealants.
You don't use it for everything then?
I'm kidding. I do not use it for sealants. But no, there should not be an issue with, I mean, it should literally be one injection for doing the restorations as well as placing a rubber dam clamp. I would say if you're placing the rubber dam clamp and they're feeling it, you probably don't have profound anesthesia.
Or it's pressure?
Well, yeah, I mean,
It's got to be one of the two.
yeah, it's one of the two, but if you've got enough to do the restoration, you've got enough to have the rubber dam on both arches.
That's fair.
Yeah, makes sense.
I hope that helps.
That does. Thank you. Appreciate you. You can mute yourself now.
Yeah, I don't know how to do that.
Next question is, can I use the Soan for just infiltration? Let's say for wiggly tooth extraction.
Yes. Yes, that was one of my slides. I was like, that is like the best thing ever. I mean, you can just, I mean, if you got to slice off an operculum or you need to, like you said, like you don't have bone, you've got just a little over-retained tooth you need to get out. It is beautiful for that.
When do you use Septo 1:100 versus 1:200? I solely use a Soan since June this year. When are you using Septo with 1:100 versus 1:200?
I recommend only using 1:200 for a couple of reasons. One, I don't want to be looking, I mean, the only difference is the color of the band. It's on the anesthetic, on the carpule itself, it's either a gold band or a silver band, and they look really similar in the drawer. And I'm relying on my team, my clinical team, to load those for us. And I want to I want to know and feel reliant that it's always the right thing in there all the time. So we just always stick with the 1:200. The other reason I use the 1:200 is your working time is 30 to 45 minutes. I don't need anything more than that. And if I did need more working time, let's say, or I needed, the kids waking up or whatever, I don't know. I would give more anesthetic versus using the more concentrated. The reason that I would recommend staying away from another reason I would stay away from it is it does have in the literature, it can have more of an ischemic effect. It can have more discomfort later because it is more concentrated. It does prolong your working time. But again, if you're doing an MO and a DO in a quadrant on a kid, do they need to be numb for 60 to 90 minutes? Probably not. So I just, it's the KISS rule, right? Keep it simple, stupid. So I just want one anesthetic in that drawer.
do you always see blanching on the lingual?
You don't always see blanching on the lingual. And I've learned that from being in the, in the Facebook group. So don't use that as your litmus test that the tooth isn't numb. Cause I don't know, I never looked for that or cared about that when I was given traditional anesthetic. I'm not looking on the lingual to see if that tissue's numb before I do a filling. So I don't, it's not gonna happen every single time.
We had another question about older patients, adult patients. Can you use it? Is it effective? If you can kind of cover that again, Anne, please.
So I'm going to start and I'll let you finish that answer, Chris. But in our
Yeah.
practice, we graduate patients at age 19. And again, there's 4 of us, 4 pediatric dentists, 4 board certified pediatric dentists doing 10 to 12 treatments a day with these devices. I have no one coming in my office saying, this sucks. I can't get my patients numb. Got a 1-star Google review. I have nothing. I have no anxiety, no stress, no anxiety, nothing over this. We're all finding a way to get our patients numb with this. Now, the company is not going to support that statement right there. That is me telling you that. The company is going to tell you age 12, I think is that they will stand behind and feel confident that you should be able to get profound anesthesia on someone up to age 12. We have found in our practice, we can push those limits. And I'm very, happy to say that. Now, having said that, Chris, would you like to comment on devices and adults?
Yeah, so I'll start with saying I've had it used on myself with success. I know Anne has had it used on herself with success.
And again, last
it,
week
it,
down here, twice now.
it really comes down to technique. It really comes down to technique and patience, right? Because like Anne was talking about earlier, you're going to spend more time. You have to have the patience to sit there, use a device, twist a device, just have the patience for it to pop through. But that needle is so sharp, it really does have to work for you. But the reason why it's really IFU speaking is not indicated for adults is because it is more difficult to penetrate through adult bone. It's more dense with manual penetration using one of these devices. But you can get creative with it. You can think outside the box. It's been done before. I think we had one more. Yep.
Y'all were
When
so
you
gentle
are-
with me tonight. Thank you so much. Everyone was so kind.
When you are in cruise mode, is there a setting that makes the administering stop at a quarter of a carp? I have noticed once I give a quarter of a carp, the device stops. So I step on the pedal again to get the light to flash and administer more local. Is this normal? And is it the same in the drive mode? Do you want me to answer that one?
Erin raised her hand. She wants it.
Erin's got it. Go ahead.
I can answer that one. So your carpial setting is probably off, is what is happening there. This is a troubleshooting call that we answer almost every day. In fact, if you're on the Facebook group, I just posted a video about your carpial setting being off. I said it, and the title of the video is "Why Did My Soan Stop Delivering Mid-Injection?" So Whitney, you can go on there and figure out how to change your carpial setting. That usually happens because when you're retracting the plunger on your handpiece, you hold down on that triangle button, or whoever is retracting it has held down on that triangle button for too long. And then you start getting into setting modes, which is why I recommend using your foot pedal to retract your plunger instead of your handpiece. So go on there. And if not, Whitney, just shoot me a text or something, and I will go through how to change your carpial setting back to a full carpial.
Thank you, Erin. While you're there, can you also answer the next question about if we have reps around the country?
It's me. We do not have reps around the country.
You're looking at them. It's the
Yes,
three of
I'm
us.
the problem.
Yes. Your reps technically are in Houston. All of our new Smile people are in Houston. But we are always a phone calls, Teams meeting, FaceTime away. So we can always help you that way. So contact us and let us know what you need, and we'll get you set up.
And just to riff off of that, we love doing, if you have a study club and you need a speaker, any of us KOLs are happy to do like something like this for your study club and teach your community about it. That's what when I got trained on this a year ago, and I had the OG Andrew, Dr. Prin and Chris come to Greenville to teach our practice. We got our bang for our buck. I put a study club together and we trained all of Greenville. All the pediatric dentists in Greenville had the opportunity to come, use the units, play with the units on each other, because we all have dental licenses in South Carolina, so we could do that on each other. And I mean, so now it's almost like I can't even market the device because freaking we all have it. And I think it's awesome. I think it's awesome that we all have it.
Yeah, on that note, look around, Whitney, see if there's anybody near you that has one, because they're your best reps. Go to their practice, ask them to, step in. Most people are pretty, willing to let you in. So, and if you don't know who they are, maybe we can help you out.
Yep. And I'll add to that too. So we get this question too. We get, do we have a demo or kind of a demo program? We do. The wait list is quite extensive. We're looking at about 5 to 6 months. It's been like that for the last 10 months or so. So if you're looking at the demo route, still kind of holding off on it for whatever reason, and just want to give it a shot first in your office, just let us know. We can definitely add you to that list, but just know that it's pretty long.
What is the cost of the unit?
Pricing. I'm going to let Jordan answer that. And Jordan, if you can also answer the last question about
Sure.
the SleeperOne too.
Yeah. So the price of the unit, we offered at $2,950 for the Soan. SleeperOne's $2,700. We do offer bulk pricing as well. So if you know for a fact, hey, you want to get multiple units outfit, the office or your multiple locations, we do offer bulk pricing. So it goes down 10-15% depending on how many units you're looking at ordering. And then the last question, oh, sorry, we have two, but one question, is there something to adjust carpal setting on the SleeperOne? There's not a carpal setting on the SleeperOne. That's only on the Soan. So the SleeperOne, you can only use in drive mode, and you have access to the full carpal. And then one more question, how long is the wait if we order a Soan this week? We have inventory to sell. So as soon as you place your order, that is processed. We ship within 24 hours. And then typically it takes anywhere between about 3 to 5 business days to actually get delivered. So depending where you're located, you can get there a little faster, might take full 5 business days to get there. So just to clarify that, we have plenty of inventory of the units themselves to sell. What Chris was speaking about was the actual demo program we have, which is very, very, very extensive. That's going to take you a while to get your hands on one and try it like that. So,
yep. Thanks, Jordan. So just to reiterate, everybody, our contact info is in the chat. You should be able to see that. Phone numbers, emails, give us a call, shoot us a text, send us an email, whatever's easier for you. We're here to help answer questions, and hopefully get you set up. But if there's no other questions, we'll give it a minute or so, but right on schedule, Ann.
And my cup is empty. That's perfect timing.
Perfect timing.
There's no way Aaron's is, so.
I saw her working on it.
Awesome.
Can you go back to the contact info real quick, Ann?
Sure.
The contact info slide in, yeah.
I got that one. And then I'm going to put Aaron's up real quick.
So my phone number has changed.
Oh, I did not know that. I'm so sorry.
You should be sorry. Changing your phone number.
I'm a piece of crap.
Changing your phone number is the worst thing you can ever do to yourself. So my phone number now is 346-287-6019. If anyone needs that.